don't adjust occlusion using articulating paper. We want that denture to be fully seated, and then we want to see where it's hitting first, what's causing it to shift. Well, if you're doing articulating paper, that denture is just moving all around. And so you're not getting good occlusion if you're using articulating paper.
How do you manage anxious gaggers or patients afraid of choking during impression? Why do complete dentures feel so unpredictable for so many dentists?
Denture fabrication should be a dentist-guided service. And we're telling the lab what to do, not the lab telling us what to do. You can make a really, really nice denture, and even you could have implants under it, and the person hate it. Now, I can't chew with this at all. It moves in my mouth. So one thing when you're asking, when you're first meeting the patient, tell me about your denture experiences. I've had several sets made lately, and I hate them all. Dentists just rip me off. Versus you have somebody that says, I've been wearing dentures for 30 years and I absolutely love them. It's time now for me to get some new ones made. These things, where the patient's coming from, are very important.
Protrusive, isn't there something really satisfying about a good complete denture with suction, good retention and stability? And you know what? It doesn't even have to be a pipe dream. You don't have to suck a complete dentures. There is a science behind it, but there's also an art behind it, an art that can only gather through experience. And so we're going to borrow the decades of experience of our guest, Dr. Leif Stromberg. If you do complete dentures, you're going to love this episode. Whether you're new to dentures or established, there's something in it for all of you. I asked him your questions from the Protrusive Guidance community, and you know what? They were brilliant. I asked him some really tough questions, but he did a wonderful job of answering them. There are plenty of techniques and nuances and even communication tips to take away for your complete denture patients. You'll hear about what is the #1 impression mistake that dentists could be making for complete dentures, and also something called pre-impression tissue conditioning. This is essentially when a patient's wearing a poorly fitting denture. They need to actually be without their denture for a while now, so that the tissues can all rebound and you can get a more accurate impression, which is very interesting. We talk about different occlusion positions. Is a Facebow necessary? All the way to, you fit the denture and the patient comes back in pain. How do you know if it's overextension or something to do with the occlusion? We did cover a lot of ground in this episode, so maybe you don't go so deep into any one aspect. We cover really good breadth. So I think you're going to really enjoy this one. Now, before we hit the main episode, let's give you your protrusive dental pearl. Today's pearl is about managing expectations and picking the right patient. Remember, you don't have to treat all patients, and you should always assess whether you can meet their expectations. You can make the world's best denture, but the patient might not adapt. So actually what's really important are the markers of adaptation. It's something I learned years ago. There was a time I was working in dental hospital doing quite a few complete dentures. And when I saw a patient who had a technically really rubbish denture and they actually really liked it, and the only reason we're replacing it is because it got worn, you know you're pretty much onto a winner, because you can actually technically improve this denture, improve the retention and stability, and so the patient's going to get along real great. Why? Because they were a great denture wearer. It's down to them and how brilliantly they managed to tolerate it, and the whole neuromuscular adaptation, which is absolutely critical. Because like I said, if they don't have good adaptation, they won't even be able to tolerate a technically fantastic denture. So something we go into in some detail in this episode, but it was worth highlighting that the patient adaptation factors are more important than the technical qualities of the denture itself. It is crucial to assess that right from the start. Let's now join the main episode, and I'll catch you in the outro.
Dr. Leif Stromberg, welcome to the Protrusive Dental Podcast. You're from Dallas, Texas. You must have good weather there. We're actually lucky that we have good weather here in England today. How are you, my friend?
I'm fantastic and so thrilled to be here with you.
We owe it all to Dr. Harpreet. She is a huge fan of yours. She sent me some of your articles, and what she's really great at, I don't know if you've ever met her, what she's really great at is her summaries, and she's like this live wire. She's always coming up with like the most wonderful questions, and what she did to help me out, because she knows I'm so time poor, bless her, is she made this like little huge document, I say little, huge document, right, with all the reflections and thoughts, and as though when she's reading your 5-part paper on everything, A to Z of complete dentures, she's like, every thought that comes into her mind, she writes down. Every like, oh, this is interesting, let me write it down. And she gave that to me, and I used half of the questions I'm going to give you is derived from that, and the other half is from our community, and which I'm so glad you've joined. You've been part of it now, and you've seen the kind of questions and the kind of people that we attract on there. So I'm really looking forward to geeking out with you on dentures. But what we need to know first from you is, I always like to go a little bit into one's journey. How did you, obviously it's very obvious to me that complete dentures and dentures, removable pros is a passion of yours. How did that come to be? Was it always the case? Is something that you discovered later in your career or very early on?
I guess in a nutshell, when I got out of dental school, I gravitated toward adult dentistry and rather than pedodontics, and kind of away from surgery also. And I started working on my mastership in the Academy of General Dentistry. And one of the things I needed to do was get some participation hours and in dentures. And I met one of the gods, the experts of dentistry, Earl Pound. Have you ever heard that name?
No,
anyway,
unfortunately not.
Earl Pound. But anyway, so I took his course. It was a 2-part, I think 7-day participation course, and it made so much sense. I just learned so much from it. But once you take a course, just one part, there is, so much to master. So I asked him if I could help him teach. And so I started going with him to do his courses so I could hear and watch him teach. And then I kind of started assisting. And later I even wrote a book on his techniques. So I really had a chance to master from the master.
It's a recurring theme, Dr. Stromberg, on this podcast, where someone like you, the expert for today, they describe their journey early on through having a mentor that they identify and being proactive. Like, you didn't just go on the course and that's it. You fought to be his assistant, right? And right, you kind of you asked the universe a question, the universe replied, right? You were proactive about it, and then you were very persistent and consistent, and then you followed what was a passion, and good things happen when all those things align. So that's a very repeatable framework I've seen time and time again from experts on the show. So let's start the geeky stuff, right? Let's start the geeky questions. First question is from Dr. Kayla. Dr. Kayla on our community asked a very good one. It makes a very good introductory question, which is about risk assessment, right? Essentially, his word-for-word question was, why do complete dentures feel so unpredictable for so many dentists? That was his word-for-word question. The way I'd like to spin it and remodel it, and I'll give you the opportunity to spin it and remodel it any way you wish will help our listeners and watchers today as well, is the way I'm going to remodel it is, whenever I do a crown prep, for example, right, I know if it's going to be simple, moderate, or complex, right? There's endo. Endo is a great one, right? You can do follow a system, and and I feel as though dentures I mean, you tell me, but I don't think they're necessarily unpredictable, but it's about knowing which is going to be the green, which is going to be the amber, and which is going to be the red, that you just know you have to opt for implants or modify the patient's expectations big time. So now I move it over to you to help us to clarify the question, but then also tell us what are the points we're looking for.
Well, I mean, this is a whole course, that question. I mean, it's not just a simple, but let's look at this. Now, let's see if this is going to answer. First thing, that person that comes to your office, you need to know what it is they want. What do they expect? And so you could make the most beautiful denture and they say, yeah, I hate this, too much stuff in my mouth. So starting out, I think one of the things that I hate the idea of is same day treatment. Need a denture? Same day. Let's get some impression. Okay. So versus who am I treating? And when I'm listening to who I'm treating, I shut up. I listen and get them talking. What are they really expecting? And then I look in. So I don't, they say I'm expecting this and this and this. I don't give them any response because I don't know what their situation is. They have a cleft palate. So then I do the exam, and there's some certain things on the exam. But I mean, you look in somebody's mouth, and if they don't have any ridge, well, you're going to have more of a challenge. If they have a cleft palate, you're going to have more of a challenge. If they don't have maxillary tuberosities, a denture is probably going to be falling down. So you just need to know some things like that. But
what kind of questions could one ask to ascertain their level of expectations? So, for example, I know some dentists who will ask a patient, what kind of foods do you expect to be able to eat with complete dentures? And then they let them answer that. And then they see, are their expectations aligned? But I also feel that if you have really good ridges and a really well-made denture, that actually you have quite a lot of dietary freedom. I don't know what you think about that.
Dietary freedom. It depends on the person's adaptability. I mean, you can make a really, really nice denture, and even you could have implants under it, and the person hate it. And I can't chew with this at all. It moves in my mouth. So so I think, so one thing when you're asking, when you're first meeting the patient, if they say, tell me about your denture experiences. I've had several sets made lately and I hate them all. Dentists just rip me off. Versus you have somebody that says, I've been wearing dentures for 30 years and I absolutely love them. It's time now for me to get some new ones made. So these things, where the patient's coming from, are very important. And I'd love the question also about what kind of foods do you expect to eat? And because, I expect to be able to eat a hamburger like I did when I was a teenager. And when they say that, it's not the right thing to do to come back and say, well, you won't be able to do that with all we're doing is getting information first. Then we're going to look in their mouth, but then we'll come back and answer the question, do you think you can help them? And then so you do a pre-examination consultation, then you do your examination to see if you think you can help them and blah, blah, and then you give your post-examination consultation and say, this is what I think I can do, and maybe ask them some more questions, but make sure we're trying to build a relationship there.
I'm going to add some of my own experiences here. I'm not prolific in complete dentures at all. I used to do a lot more in a previous environment, a hospital environment. I do very little now. But what I do remember is I used to work in this referral clinic, and I used to work with a specialist alongside me, prosthodontist, and then there'd be like 8 patients. We'd walk around, and then we'd get all these kind of referrals. And there was an interesting referral letter from a gentleman saying, I've been making dentures for 30 years. I use this Gerber articulator, and I use this and stuff, and I think this denture is excellently made, yet this patient is not adapting. It's your guys' problem now. But actually, when I looked at it, no disrespect to his referring dentist, but I was expecting to see a masterpiece. But actually, it was very short. It was not covering the hamular notches. It was halfway along the palate. There was so many things that even as a novice back then, I was able to identify that, hang on, objectively speaking, there are some things that could be improved here. I think personally what happens is that the patient persuaded or coaxed the dentist to not allow the denture to cover as much as the dentist would have desired, and therefore the subsequent denture was a little bit substandard. It didn't have enough retention, and the patient then probably understood that when getting another opinion that actually we do need to cover all these areas. And then the second time when I made the denture, it was brilliant. It was great retention, great stability. So that really taught me that sometimes you have to assess the objective. And then the other experience I've had relevant to what you're saying is that patient who has been wearing the flimsiest denture so well for so many years, for me, I will take that case on any day, right? Yeah. Because that is a home run case, in my opinion.
Excellent. Neat stories. Thanks.
So the next question I have is, Dr. Stromberg, in your papers, you mention about denture problems are theirs, not yours. Okay. Set aside your emotional side from your objective side. Okay. So that's something that you have said. So does that mean that denture problems are sometimes more about anatomy and adaptation rather than the quality of the dentures itself? And then if so, how can you determine that as early as possible?
I think what I was saying, the denture problem is theirs. This is mental. The problem is their problem. They have to own the problem. Often the dentist owns the problem. I have all these problems with this patient, and the dentist feels really bad and takes on the problems. Well, they're not the dentist's problem, but I am here, patient, to help you with your problems.
Mm-hmm, mm-hmm. And so how can you get the patient to accept that and own their problems, which is important in any part of dentistry, right? But without making, in a most respectful way as possible.
So this would probably come after the consultation, the examination, and now that we're talking to the patient, we're not promising, oh yeah, I can give you a new set of teeth that you'll be just like you were when you had your teeth, and this is going to be wonderful for you. Let's get started today. So we're not going to do that. We're going to, we want them to own the problem. And, I can make, let's talk about some of, I've already talked to them about their denture history. So I know a little bit about that. And, I think I can improve on the aesthetics. I think maybe I'll try to improve on the phonetics if those are their problems. But I'm not promising that I am going to do those things. But I am going to say we're going to try an appointment where you'll see the teeth set up and approve them before the dentures made. You can try to speak with them and see. And so I won't make the final denture until you approve them.
Mm-hmm. Mm-hmm. That's good, because it gives patient the reassurance that the bit that they're most concerned about in that case will be trialed. And that's obviously why try-ins are incredibly important in what we do.
They sure are.
I have an interesting question now. I'm going to get you to rank. There's like a fun question, right? So I know you haven't seen any of these questions, but I'm going to get you to rank the following, okay? In terms of which ones are the most important, right? So for example, let me give you some more context. The Pareto principle, right? So 80 of your problems are caused by 20 of the staff or something if you own a clinic, okay? Or 80% of your complaints come from 20% of patients, right? The 80-20 rule, okay? So with the hundreds of things that are variables that we look into, the patient adaptability, the technical quality of the denture as well, I want to really fine tune, okay, of everything, what are the 20% that is the most critical, that if you get these wrong, then actually the denture will be more likely to be failed, right? So that's the kind of context and frame I'm putting on. And so I'm going to get you to rank the following. It's very difficult what I'm going to give you, so please bear with me. But I'm going to get you to rank all these points, okay? So number one is extension and coverage, i.e. how much surface area your denture covers. For example, the lower complete denture covering a third to a half or more, you can tell me later, of the retromolar pad. The upper denture covering the hamular notch. So number one is extension. Number two is the occlusion, okay? Number three is tooth position, i.e. how far in the middle of the ridge the tooth setup is, if, to buccal, to lingual, so where is the tooth position. Number four is centric relation and actually getting perfectly into the centric relation joint position. And number five is patient communication, okay? So I know this is like the toughest question you've ever had in your life, but if you had to rank those five, and I'll tell them again in terms of which is the most important of those five, and then work your way down, and we can have a chat about each one, right? So extension, occlusion, tooth position, centric relation, and patient communication.
Is occlusion and centric relation the same thing?
No.
No.
We've put down centric relation as the actual registering of that joint position, making sure, because obviously they're very much related, but the ability to accurately record the centric relation and getting a good recording versus the occlusion actually being the correct occlusal setup, balanced occlusion, the correct guidances.
Gosh, they're all so important. So I guess let's say that the most important is centric relation.
Okay. And
so when those dentures go in, they're closing and all the teeth are meeting evenly in centric relation.
Okay, brilliant. Okay, and so I'll let you continue because there's a separate questions I have about CR. So centric relation being the top one there. If you get that wrong, then the denture is going to have more problems than the others. Carry on.
Let's go. Let's go tissue coverage. So it is so important for the dentures to cover as much tissue as possible, but not be overextended.
Good. And the other ones are tooth position, patient communication, and the occlusion in general.
Okay, let's go patient communication because it's so important. If the patient communication's not there, chances of having an unsuccessful outcome are very high.
And then tooth position and the occlusion itself.
I'll go with tooth position, having the teeth in a nice position. I do not believe in teeth over the ridge. I've got a whole set of ways of determining where, because ridges don't just resorb in an even way. Some areas more than others. So how can you think that's where the most favorable position is for the tooth is over the ridge? It's just kind of a simple way to teach. But there are ways that Dr. Pound showed me that you can determine tooth position to make things where they look better and are more stable.
Okay, so his next question is from Danielle Kerr. At what point is it necessary, is it ever, okay, to design a maxillary denture in a class 3 position, even when the patient is insisting that their anterior teeth were always lined up before, but their premaxilla is now severely resorbed. Okay, so this is a two-pronged question, because it talks about the norm of class 1, okay, and therefore do we have the permission from the denture gods to do a class 2 division 1 denture? Can we do a class 3 denture, okay, as the first thing, okay? And then the other thing is, well, when the ridge resorbs so much, then how far can you actually put the teeth forward to the ridge for aesthetic reasons, but then, you know, at some point you're going to tip the balance and now it's not going to become functional?
I always try to position the teeth where they were originally.
Mm.
And even though somebody may come in and say, I want more tooth to show, blah, blah, I'm going to start out where were they originally and then see how I can adapt from that. So the teeth are missing, lots of ridge resorption, well, there's some certain guidelines that anterior teeth are usually 8 to 10 millimeters, central incisors anterior to the center of the incisive papilla. And so that's where I'm going to start putting teeth, even though I don't put teeth over the ridge. So you're kind of almost making, since the ridge is resorbed, we're going to put the teeth back there. Nope, that's not where I'm going to put the teeth. Then I don't know if you asked something about, class 3. I mean, you can make wonderful dentures for a class 3 person, but it's not because of where the ridge is, it's where the teeth will function the best.
And so when they're functioning the best, that's when you're looking at their skeletal patterns, right? And you're trying to follow their skeletal patterns, and maybe they always were a skeletal class 3, and that's why the denture rehabilitation will be in a skeletal class 3. But in this specific scenario, let's modify the scenario whereby, yes, you can use an Alma gauge, as you've written about. Basically, I was always taught 9 millimeters, but yeah, 8 to 10 millimeters in front of the incised pillar is the incisal edge of the upper, and you follow that. But then the patient says no, they want it to come out even further. Okay. How do you manage that? Because then you got the lip and the neutral zone and then instability. How do you sort of fight that battle?
If I think I might be able to help them, I'll try. If I don't think so, I might just say, this is the best I can do. And if this is not what you want, I think anything else, bringing the teeth out further, making them longer, is going to make the chances of us having successful dentures much less. And so I'm not going to do that.
Okay, that's fair. And so just being very upfront about that's fair. A question from a regular contributor to our community and sending in questions is Dr. Kostas. He asks, how do you manage anxious gaggers or patients afraid of choking during impression?
Sometimes I would spray in their mouth a topical anesthetic. And one thing I always do is I always mark the posterior of the denture. Where is the posterior going to be? So it's going to be in the hamular notch. So I use a little indelible ink marker and I put a little mark there. And then I mark the vibrating line on different little things across their mouth. So I can look in the mouth and say, this is how far back I need to get. And then also I use what's called AccuGel. It's an alginate impression material, and it doesn't really just flow down their mouth. It's really controllable. So there's another thing with that. I could, but then, and so if you use that alginate system, the AccuDent, you can get good peripheral border impressions, but it's not running down their throat. So I think you can do things like that. Another thing you could do is you could use nitrous oxide and just have somebody, because the AccuDent it just goes in, and I have had people, gagging around and just a minute, and just by using a little topical. But different people are different ways, and sometimes you have to go to different extremes.
I've also heard about some salt on the tongue. I've heard about that one, never had to use it. The other one that I use regularly for radiographs is putting pressure just by the mentalis. It's acupressure, or you can use acupuncture, or you can with the actual needle, the acupuncture needle there, and I believe it's CV24 from the course I did a few years ago. Shout out to Dave. Or actually just getting the patient to keep their finger by the mentalis, pressure, and you'd be amazed about how that can suppress the gag reflex as well. So with your tip of using these sprays, topical anesthetic sprays, and salt, and all these kind of things, and actually the choice of material that you made as well is very important, because it sounds like it's a bit more viscous.
It is. It's a fabulous material. By Occlusal. Yes, it's really something that I recommend people take a look at.
Brilliant. I'm going to circle back to a point you made earlier about figuring out where to place the teeth on the ridge. Now, yes, we've talked about anterior teeth and the Alma gauge and putting it, 8 to 10 millimeters and using the incisive papilla as a reference. But let's say lower molar, premolars, molars, or upper premolars, molars. How do you get a stable denture if you're not following the ridge itself? Because if you're too buccal or too lingual to ridge, are you not risking tipping?
This is kind of like, it's called the pound triangle. Have you ever heard of that?
No, tell me more.
Earl pound lingual control lines. And so what it is we first will have the anterior teeth determine where they are before we determine our posterior teeth. And this is done on the cast once the things are mounted up. So if you draw a line from the mesial of the mandibular canine to the lingual aspect of the retromolar pad, the teeth should not be any lingual to that. If they're any lingual to that, they'll be getting in the way of the tongue, and the tongue will make the denture kick out. But let's say that the upper ridge is, so the more lingual you can have the teeth, the lower teeth, the more stable they'll be. But let's say the upper ridge is very wide compared to the lower. So you might have to bring that lower tooth out so that the upper tooth can occlude with it. So you can bring the lower tooth out as far as a line from the mesial of the canine to the buccal aspect of the retromolar pad. So you have a little triangle from the mesial aspect to both sides of the retromolar pad, and the teeth need to line up in there. The lingual aspect of the teeth needs to line up there. So when the laboratory is setting teeth, they can look at the upper teeth and say, oop, we need to, if we bring it in too far, we're not, it's not where the teeth used to be in relation to the ridge. But those lingual control lines are very, very important.
Yeah, we'll try and pull them off and put them on the screen for those as reference. Thank you so much. And why is it that the more lingual the teeth are, that the more stable your denture will be? What's the anatomical reason behind that?
Just as teeth go more and more to the buccal, the forces cause the denture to rock more. So if the teeth are more toward the buccal and they're putting pressure, versus if they're more toward the lingual, it more tends to seat the denture.
Okay, the next question is, what are the biggest mistakes dentists make that you've observed from teaching and observing during the impression stage? Okay, so this could be any primary, secondary, just general mistakes that you've observed, that you've made in the past when it comes to impression making.
Boy, it is something when you look at the laboratory and all the unacceptable impressions that go to the lab.
Hello, YouTube Protrusive. I know you're watching on YouTube, and I hope you're enjoying this episode so far. But I wanted to highlight, in case you don't know yet, we have an amazing viewing experience on protrusive.app, our website, our network, our platform. So I just want to spend a minute to show you what this looks like. On the left side, you see the navigation, and when you join the app, you get a 1-minute video tour of the entire network. Now, in terms of where the magic happens, that's in the Protrusive community, because you might come for the content, but you'll stay for the community of the nicest and geekiest dentists in the world. We have all these polls, we have a chat group, there's always active chats and dentists helping dentists. And really what I wanted to do is create a really supportive environment that's not like the environment we have on Facebook, and is built on the values of niceness and geekiness. If you are nice and geeky, you belong here. Now, to make this a safe space, we have a manual process of approval. We actually verify that you are a dental professional before you get in here. So we have hundreds of applicants a day. So if it's been about 2 days and you haven't heard anything, either something's in your junk or you need to reach out. If you're still waiting to join your tribe, email marie@protrusive.co.uk. That's MARI@protrusive.co.uk, and she'll investigate what's happened. Now, all the videos you have on YouTube are also on here, but you actually have some extra ones for free that you don't have on YouTube. So you get some bonus content that's not on YouTube. And actually for the future, I'm not taking things out of YouTube, but some things are not appropriate for the wider it public, and I want to sort of safeguard that information, which is like dentist talk, if you like. So that's why a lot of the content is only here and not on YouTube. So you're kind of missing out if you're not on here. That's why I'd love for you to join there. And if you join one of our paid plans, then what you get is access to the CE quiz like this one, and you can get CPD or CE certificates, and also you get our premium notes. So these are a great aid memoir or revision for an episode to really cement your learning. And whilst we have ads and YouTube places ads on YouTube, we don't have that on our network. So for the paid plan, you get to see all of the premium notes without any of the ads. And of course, you get to support Team Protrusive and help us to continue what we're doing. I'm just going to gloss over the Protrusive Vault, which has all our infographics and downloadables. These are all our masterclasses at this moment in time, and we're always planning to add more. And if you look at them, there's about 1, 2, 3, it's about 7 of them. But actually, if you look at the replay section, some of the live masterclasses that I've done and some of the training that people pay for on other websites is all on there, included as part of the masterclass subscription. And if you're a student, don't fear, we have a special section for you with all the student notes, which anyone can access. So for example, here is one on exodonture. So it's all there waiting for you on Protrusive Guidance. Please head over to the website, which is protrusive.app. Make an account on your browser. This could be Safari, Chrome, however you want to do it. And once you've made your login, then you can download the iOS or Android app and then log in through there. So the reason to make the subscription primarily on the website first is that you get access to a free trial, which you don't get if you make an account on Android, iOS. If you make it on the website, you get access to the free trial, and you get our best price if you sign up through protrusive.app. So our best deals and free trials are only on protrusive.app. Of course, we always put the link below in the description, and thank you so much for enjoying our videos on YouTube. But it's now finally time to level up your experience. Back to the episode.
And then these labs now that have are digital, and they're getting all these really bad impressions, but their dentists are saying, make them work, make it work and the best you can. So they have it, the digital denture put out on some. So I guess it's so important for the denture to cover as much tissue as possible, but not be overextended into the muscle. So, and it's very important for uppers, for good retention, for the denture to extend back into the hamular notch that's distal to the tuberosities. But if you just take an impression, send it to the lab, or even these digital impressions, and they just say to the lab, make denture. I've asked the lab, well, how do you know where to extend it to? They said, we don't. Part of my system, my belief is this denture fabrication should be a dentist guided service. And we're telling the lab what to do, not the lab telling us what to do. We're telling the computer what to do.
How far do you think we are from an impressionless world where you can scan and then a denture can get printed for you or made for you and then sent and posted back to you without any alginate, any silicone, any impression material having touched the patient's mouth?
I cannot answer that. I use analog techniques. I use my alginate, so I don't, but I know that I'd say that dentists who are using the scanner are probably not doing very good dentures, not giving a very good service. But I hope someday it gets better and better. Another thing, maybe they can get it. So another thing, what if before you scan, you take your little indelible marker and mark the posterior border in the mouth? Then you scan. Dang it. Then it's not going to be overextended or underextended.
Well, here's an idea as well I've always thought about, and I'm just voicing it now, and maybe it's going to come out really stupid when I say it, and maybe I shouldn't have said it, but how about, what if you scan an edentulous upper ridge? And then the lab makes a denture, prints a denture, but it's intentionally a little bit shy of where they think it would be, right? And then you use chair-side acrylic, your acrylic, and you like green stick, you put it all the way around, and then you functionally mold that in the patient's mouth. Okay, let it settle. It's going to heat up a bit. Okay, put some Vaseline everywhere, and then let it functionally mold in the patient's mouth. So then the peripheral seal, and then obviously you can make your own post-dam as well. Is that something that has legs?
Absolutely does. I think you're onto something, and. So what I would do, and I'd have that initial denture, say, printed or whatever, but hopefully it has really good occlusion, good vertical dimension, good tooth position too. It's not just one thing.
Well, no, I was just wondering whether are the analog days numbered, but not quite. But
I know.
Yeah.
I would do a reline with a tissue conditioning material. And so if you use like CoSoft and and then the patient can say, they like the denture and now they like the retention, then send it to the lab for a reline.
Okay, perfect.
You've made the denture off a scan and it's not going to have good retention. But if you reline it and do a really good reline, really careful, then you could maybe adapt that into a really nice denture.
No, very, very good point. And now on the topic of impressions, you wrote something about mouth preparation before the final impression. Okay. So asking the patient not to wear dentures for 24 to 48 hours and this kind of stuff. So tell us, how important is this? Because a lot of patients will like, I cannot be without my denture for that long. I'm sure you've heard that one before, but how important is that for a well-fitting denture at the end of it? And what are the different things that in an ideal world your patient would do?
So one of the things that I mentioned at the start, and I truly believe, is when you do the examination, you should not be if you want success, you should not be making a denture to a oral condition or a facial condition which is unhealthy. Okay? If the tissues are inflamed because the old denture is causing sore places or what, if you take impressions of that, you're making a denture to something unhealthy. Let's say that it does heal up, well, then the denture isn't going to fit anymore. So one thing you might do in that case is put a tissue conditioner in there. Or if the patient says, no, I won't do it, and you say, well, I'm going to have to use tissue conditioner, and it's going to be $85 each visit to change that to get your tissues healthy. Or do you want me to make it to your tissues when they're unhealthy, and then you'll have a denture failure? It's their problem. But if they won't do it, then it's not your fault. It's their problem.
And what else is it? Like, obviously, no adhesive, not wearing their dentures for 24 to 48 hours. How can you create that optimum environment? Because great point about the inflammation. And
even that 24 to 48 hours, that may or may not solve the problem. But it's at least if the denture is causing irritation and the mouth. But so the more healthy the tissue, we're trying to make something that's going to fit and work for them for years. What do we have to do? Be real quick? Well, I can't do it. But, let the patient know what we're trying to do. But if the tissues aren't healthy, probably the dentures won't fit well. But another quickie, jaw joints being healthy. I mean, so if somebody has jaw joint problems and you go and you make really gorgeous dentures, keep position correctly and deliver it, and then the jaw joint changes from the way it is when you recorded it, the denture's all off. So a healthy system means healthy jaw joints. And so if you want success, it's good to understand jaw joints and be able to check. Two-handed manipulation, verify centricalation. If I can verify it, then we go on. If I can't, I don't make that denture for them.
I was just going to ask what you do, but you've been very categorical that actually you can't. It's like chasing a moving target, right? But when they have unsound joints, 2/3 of the occlusion is the left and right TMJ, right? So it makes perfect sense. The whole analog versus digital, by the way, that was a question from Anu. Anu, thanks for that. Next one, I really like this one, okay? Something I read about from Harper Deep's wonderful document about, and it pointed out something I learned that may actually be wrong, and I'd love for you to teach us why it could be wrong and why there may be not necessarily wrong, but there might be a better way, right? So I was taught to find the vertical dimension of rest, okay? And one way to do that is to get to the patient to bring their lips together and just just gently blow, just ever so gently blow until the lips just come apart, okay? And then that is like the vertical dimension of rest. So if you measure that and then you deduct, 4 to 6 millimeters of freeway space, that would be your vertical dimension of occlusion, okay, that you're going to then record. But from what I read, is that you're not a fan of using your vertical dimension of rest as a reference to be able to determine your vertical dimension of occlusion. Did I interpret that correctly?
Yes, you did. And so somebody comes in with a vertical dimension of rest, let's say in the morning, they come in all relaxed and everything. They have what if they come in and you're going to record their vertical dimension after a hard day at work and they're upset and they almost had an accident? You do that. Well, muscles are good. Vertical dimension of rest fluctuates. Another thing, you said 4 to 6 millimeters. I mean, well, why 4 to 6? Why is it 4 or is it 6? What we don't want is those teeth to touch when the patient's speaking. We want a speaking space. What is the most closed position of the mandible when somebody is speaking? When they're making S sounds. So if we can look at this patient coming in, and we, no problem taking vertical dimension of rest, and we say, let's say it's 70 millimeters. And then, so we know that vertical dimension of occlusion is going to be less than that. Well, then what if we have the person say 66, 67, 60? So the vertical dimension of rest was 70 when they're saying 61, 62, maybe it's 68 millimeters. It's a little bit more closed. And so then we know it's even going to be another couple millimeters, maybe 3 millimeters more closed for the vertical dimension of occlusion. So using there's too much play in using vertical dimension of rest. But it is a reference, and sometimes people, it's not even close to vertical dimension of rest when they talk. Their teeth are so long. So, but the closer you can have to a vertical dimension of occlusion that the teeth don't bump when they're speaking, the more chance you have of success with your dentures.
So don't just rely on the vertical dimension of rest, also add in the vertical dimension of speech to help to calculate your vertical dimension of occlusion.
Gotcha.
Lovely. Okay, great. Next question.
And then you go to your wax try-in and you verify that you're okay.
That's a great, okay, well, let's talk about wax trying then, right? So I remember having this patient years ago, one of those patients who's not a great denture wearer, and aesthetics looked good, speech was good, but his main concern was, but usually when I take a denture home and I try to eat, it hurts me. It hurts my ridges. And then at that point, we're like, is there a way to test that at the try-in stage, or does it have to get fully processed and then in acrylic and then they take it home to be able to test that? How far can you go with the try-in? What are the other ways that we can test the functional adaptation rather than just speech and appearance?
Okay. So I'm doing a wax try-in. So what they have is something that I say we're trying to evaluate the aesthetics, the tooth color, tooth position, tooth shape. Okay, that's what I want the patient to evaluate and approve. I don't want them to approve the function. I don't want them to approve and so I'm going to have them speak, and I'm just going to watch. But what they're really doing is evaluating the aesthetics at that point. I'm also going to say that the denture should be sent to the office on the articulator that the case is going to be worked on. So we can look at the occlusion on the articulator, the occlusion in the mouth, and see if things are the same. See if things should be moved. Just having two dentures in a little cup, you really can't evaluate how you want it to change, because we're looking for some precision. And if we're careful on some of these things and we know what we're doing, we can really get precision.
Yep, I appreciate that. In which case, I'm going to ask you then, how important is a Facebow registration when it comes to complete dentures?
Well, people hate me on it because it's very low on my list. So, but you know what? People take their bite relation, centric relation, vertical dimension record with wax rims. I'll say if they're using wax rims, they're probably off almost all the time. It's just so impossible to guide the jaw with these things falling and moving around. A Gothic arch tracer is so easy, and you can this has just helped me so much. I can precisely record centric relation, precisely record my vertical dimension. Then the lab can mount the case, and then I also say, I send an articulator with the case to the lab and say, mount it on this. Because if they mount it on one articulator, which they do, then sometimes they send it to the other department, they put it on another articulator and start setting teeth. The articulators are different. So keeping the teeth on the setup on the same, so it should come to my office on the articulator that it's going to be finished on and everything.
That's really great that you've explained, okay, so Facebows aren't that important, but the fact that they're articulated is important, and to make sure that there's consistency in the articulator throughout the production of the denture. Centric relation, you said already, super, super important. And one of the questions I actually had for you is, I was taught traditionally to get the patient to curl their tongue to the back, okay? And that's at some point, yes, you can record in the wax jaw registration stage using that technique. Whereas what you're
And
using...
you'll be wrong if you do that. You know you won't have centric relation if you do that, okay?
But this is something that the dentists are doing all over, right? And then there's some adjustments to do at the fit, etc., the try-in, etc. Teeth are popping off, and so we've all been there. So I was going to say, okay, so I was going to ask you, what is your preferred way of finding and recording CR and vertical dimension? Sounds like, yes, it's the Gothic arch tracing. And actually, you said it's way easier than if someone's never used it before. They think this is like this really difficult thing to do. But actually, you've said, okay, it's actually quite easy. But the barrier, Dr. Stromberg, the barrier is the fear of the unknown and not having done something before and doing it for the first time, right? And so can you help the dentist listening and watching to understand, okay, what is it that they need to buy? Or is it just some quest from the laboratory? Is the laboratory that do all the hard work? And just give us the idiot's guide to using a Gothic arch tracing for the first time.
And even before I do that, I'm going to throw in Facebow transfers. I've been mounting my dentulous patients on articulators with Facebow transfers for decades. I know where, how. So when I'm putting models on the articulator, I don't need a Facebow transfer always. I can kind of eyeball it. If somebody doesn't know when where the teeth should be on the articulator, it really may be important for them. So now, Gothic arch tracer. It's important for the laboratory to know how to use a Gothic arch tracer also. A lot of them don't know how. So one thing to think of the lab is ask them, do you have the setup for a Gothic arch tracer that you can loan me? And if they say no, well, they can sure help guide. Maybe they can help guide you if they know, but they may say, a lot of labs don't even want to get into it. Hey, we do only things this way. And, you start getting into this other stuff. We don't even want to have anything to do with that. So get to know your lab and dentists be the guide for your service. So is that, you need to have a lower pin and an upper flat plate so that And
is that already embedded in the wax jaw restoration by the lab, right?
Yes, it should be, right.
And it's a matter of just recording the forward, left, right, forward, left, right, and then getting the point, and then that is all transferred to the lab, and they can take it from there.
That's right. Absolutely. And then I make a wax rim for the upper, and I use that wax rim for tooth position of the anterior teeth. How long, where's the incisal edge position? So, if you send it to the lab, just a Gothic arch tracer, they will say, where do you want the teeth? But if you can say, this is where the upper anterior teeth go, according to this aesthetic wax rim with a midline, they can set those and they can set the lowers to it. Then they can set the posteriors.
What stage does this aesthetic wax rim come in?
Same appointment, the records appointment. So first appointment, exam, second appointment, impressions, third appointment, records. And so the records is Gothic arch tracer and tooth position.
Okay, perfect. So you can't get everything from one recording, the Gothic arch tracer and the tooth position in one?
No, it's better not to. Okay,
no, that's super helpful. Thank you. So there we are, guys. The first step is just pick up the phone to your lab and figure out, are they using it? Because they can guide you, okay? They can loan you, they can guide you, and that's really it's so important in complete dentures to have a friendly relationship with your technician, because they can make or break you. I'm sure you'll agree on that.
Boy, do I ever. Yes, sir.
Here's a question from Dr. Michael King, a really lovely guy, very experienced dentist, mentoring so many of us on the community. He asks, how do you differentiate pain caused by overextension versus pain from occlusal stroke parafunctional issues? So occlusal overload versus overextension pain.
Well, I guess let's say this is pain when I'm delivering the denture. So I'm putting the denture in and we have some pain here. I'm going to use pressure detecting paste and put some on it to see. So important that we want this denture to seat on the tissues and cover all the tissues, not have any gaps or not hit too hard in some place. So you put it in. So if we get it where we have really good, and so in my my work, we talk about how to really understand and learn the art of pressure detection paste. But let's say we've got good contact all around and it's not hitting hard in the back, but when they bite down, there's still something there. Well, then we can check the occlusion. I might also say one of my fundamentals is don't adjust occlusion using articulating paper. We want that denture to be seated, fully seated. And then we want to see where it's hitting first, what's causing it to shift. Well, if you're doing articulating paper, that denture is just moving all around. And so you're not getting good occlusion if you're using articulating paper. So you can remount the case, or in my courses, I talk about how to use Occlusal indicator wax. Let's just say you did a remount and you put it back on, you see, oh, yeah, this tooth is hitting hard back here. And then if you have a really accurate remount record, then you can adjust the occlusion there and go back in and see if that takes care of it.
I remember early in my career, we managed to solve and rescue a denture where it was having all sorts of occlusal issues by what my tutor at the time called a pre-centric check record. So at that first point of contact where there was that interference, we recorded that position and then we mounted it on the articulator, and then the technician was able to do the adjustments to bring it all together, and then that helped massively. And your point of being careful with articulating paper because then the denture is moving around, I think that point is exemplified or accelerated the thicker the paper that you use, which is traditionally what we use in denture. I would argue that there could be a scope for thinner paper, like for example, if you ever use troll foil, you're shaking your head, you're against it. I respect that.
I love troll foil and I love AccuFilm and use them all the time in my practice. But if you're marking it and it's hitting first, like you were talking about that place, that whole denture is going to shift and it's going to mark all over the place.
Understood.
You're not going to get that one spot. And if you're let's just hold the dentures in position and guide them. Well, the tissues, if you're getting a really good bite for a remount, or if you use this Occlusal indicator wax, it's just a real thin layer of wax you put over the teeth, close the patient into the wax, and you can see, it's almost hitting here, but it's not hitting these other places. Let's grind this over here and then that way they're biting into something that seats the denture evenly. And so but if you're really doing a good Gothic arch tracing and the lab's being careful, almost no adjustments are needed when I'm delivering a denture.
No, well said. Now, I've got my final question, okay, because today was very much, let's throw all these weird and wonderful random denture questions plucked out of the universe and from different people from around the world. And we've kind of agreed already that, okay, maybe in the future, we're going to focus on one appointment or 1/10 of one appointment and go deep on one aspect, which can be really fun. But thanks for participating in today. For you as a guest, it's not been easy because the different angles and the switching you've had to do. So thank you so much for everything. And so I promise this is the last bit of torture, but we appreciate it so much. Everything you're saying is so helpful. So the question is about cuspal angles, right? You talk about anatomic versus semi-anatomic versus non-anatomic, right? So how can you determine the cuspal angles that your patient can receive? Why does patient A deserve or able to tolerate anatomic cuspal angles? And why does patient B need to have flatter non-anatomic?
I make my cases with lingualized occlusion, where the upper tooth is anatomic and the lower is semi-anatomic. So the patient has an upper cusp, which hits in the central groove and is good for mastication. You have a good cusp teeth chew better than flat teeth. But if the lower tooth is more flat, the teeth are not locked in. So I can use this for everybody. And then if for some reason we have to flatten it out a little bit more sometimes when they say, well, I'm having a challenge for this or that, and I decide I need to flatten the lower teeth, I may flatten the lower, but I'd never flatten my upper lingual cusp. I keep that as a long cusp so it penetrates food and they chew better. And it actually looks so much better too, having anatomic teeth rather than flat teeth. So my lowers is more flat than the upper.
That really helps. And what's the difference then between anatomic versus semi-anatomic? So I think it's basically, it's not, so semi-anatomic is not completely flat. It's just have shallower anatomy.
Yeah, I think it's 15 to 20 degree, they call it in anatomic. So anatomic is like 25 to 35%. So it's a lot steeper cusp, and then flat is 0 to 5%. And you can do lingualized occlusion against a flat plane lower tooth, but it's kind of uglier. So if you use a semi-anatomic, then you're just kind of bringing in more aesthetics in the case too.
Amazing. Well, that's all what we have time for today. We covered a lot of ground, a lot of different angles from appointment 1 to all the way to the last appointment. We covered pretty much a lot of topics from every appointment. So thank you and sorry for the different angles. We'll do a bit more structure next time. Today was like a nice to meet you, Dr. Stromberg, but I'd love to do a deeper dives. But I would love to send a message to everyone. How can we learn more from you? Okay. How can we support what you do? How can we learn more from you?
Okay. So in order to learn the fundamentals, I have written 5 print courses, which are presented in dentaltown.com, and you can go, they're free.
I'll put the full link to yours, the direct link in the description for you.
And there are 5, I think there's 6 courses. I have the records appointment broken down into two separate little courses. And then also on Dental Town, I present a 5-part video series that goes through the exam. And so if you learn the fundamentals of the exam, the fundamentals of impressions, and then when you start doing implants on retained dentures, if you know the fundamentals, you'll be much more successful. And same thing with, I'll say, with digital, and I get all kind of shook up because digital, these people, they're trying to sell you a system, but you be in control, dentist, and if you know what's there, they have some wonderful things in these systems, implant systems and digital systems. But if you know how to guide it, you're the one that's going to come up with success. They're not going to have success for you. But dentaltown.com for continuing to study my fundamentals.
Great. I'll put a direct link there so that they can find all those wonderful resources. Another big shout out to Dr. Harperdeep for the introduction and for the hard work she did and just summarizing everything for me so I can take a little bit from each appointment. And then we look forward to reconnecting in the future for a deeper dive in one specific area, because there's about 50 other questions which I could have easily asked, but it's nice to do it in a different structured way, and we'll run out of time. So thanks so much, Dr. Stromberg. So nice to see you.
Jazz, it's been great. You're such a neat person. It's so much fun to be with, just kind of like I've been with you. I thank you for having me, and I look forward to working with you some more.
Thank you so much.
There we have it, guys. Thank you so much for covering so much ground with us with Dr. Leif Stromberg, so many different themes, and didn't he do a wonderful job? Like, on reflection, I think 1 or 2 of my questions were a bit poor and a bit unfair and a bit tough, but what a great job he did. Your questions sent in by the community were excellent, as always, and if you're not part of the community yet, then what are you doing? You're missing out, especially if you're reaching to the end of these episodes. That means you're a true fan. You need to get on Protrusive Guidance. It's a free app before you start downloading it. Head over on your browser to www.protrusive.app. Make a free account. We're going to then manually verify you because it's dentists only and dental professionals only. We need to keep this a safe space. Once we verify you, you have your account. You can then use those same login credentials on the iOS or Android app. Now, for those of you who are already members, thank you so much. You can get your CE and CPD just by scrolling below, answering the quiz, get 80%, and our CPD Queen Marie will send you your certificate. We are a PACE AGD approved education provider. Don't forget to join Protrusive Guidance, my friends, and my thanks again to our guest, Dr. Leif Stromberg, for answering all our questions about complete dentures. Thank you so much, my friends. I'll catch you same time, same place next week. Bye for now.